Hi, I'm Dr. Liz O'Riordan and I'm really sorry that I can't be with you today, but it's a pleasure to be able to talk to you about what patient-centred care means for me. And I think as a consultant breast surgeon, patient-centred care for me was doing the right thing to the right patient at the right time, giving patients the best operation I could so they'd leave the room with a pretty scar and I'd see them back at a year all happy and smiling. But I never really focused on what their quality of life was like when they left my room. I was purely focused on surgery. And then I became a breast cancer patient myself, and I realised breast cancer changes a patient's life completely, not just physically, their body image, how they feel, the side effects of all the treatment, but mentally, psychologically, how they cope, the grief of things they've lost, the worry about it coming back, the impact on their relationships with their family and their friends. And I realised that I wasn't really helping my patients fully. I naively assumed that my team were doing it all for me. But I'd never sat in the room with my breast care nurse when I left to hear what she said. Was she filling in the gaps of the knowledge that I wasn't? Or was she just going over everything I'd told the patient because it was still sinking in? They just heard they had cancer. I had no idea whether the GPs knew how to help women cope with the problems of the menopause or the fear of recurrence. I had no idea what they said. I was purely focused on doing the right thing for that patient. And I think patient-centred care has to realise that patients are people. We are not diseases. And it's no good giving us the best treatment that you can in a tertiary centre if our quality of life is miserable when we leave that hospital, when we leave that clinic, and that patients have lives, and that we need to talk about their mental health, the psychological health, help them get their sex life back, talk to them about exercising and eating and how to actually feel healthy again. And another thing I realised when I started talking to women who'd had breast cancer was a lot of them make decisions that as a surgeon I would have thought were stupid. Now, my husband says for a very intelligent woman, I can be very stupid at times, and he's right. But I've sat in clinics where someone said, yeah, no, I don't want that. I just want a mastectomy. I don't want any of your faffing. And I'm like, but why? I want to play. I can't get inside their head to see why they are making that decision. And if it's something I disagree with to the core of my being, it's still their choice. And as long as it's an informed choice, that has to be okay. I think for true patient-centred care, we all need to take some time and put ourselves in the shoes of the patients we're treating. And I never did this as a breast cancer surgeon. I had never been on a breast cancer forum to read the questions my patients were asking. I'd never gone online to look at people talking in the breast cancer space. What were they searching for? What information did they need? Did you know there are 1,200 cancer diet books on Amazon alone? Patients are desperate for information and they're not coming to us. They're not talking to us for whatever reason it is. And I think it's that joined up thinking. We treat patients as a team, and we need to make sure that some person in that team is responsible for dealing with every aspect of that patient's life. You may not be the person to tell them about how to get their sex life back, but you should know to tell them who they can talk to. We should know how to help patients get the psychological counselling they might need, or where to get that support from other patients, because cancer is a really, really lonely illness. Think about things like psycho-oncology. Think about how we can just help them live again. And I think it also comes down to, we need to support the people who look after patients. Because I remember as a junior doctor, I never saw my consultants cry. There were cases where I wanted to cry, those heartbreaking cases of young women who were pregnant, who were dying of metastatic disease. But as the consultants at the top of the field, we just have to get on with it. We go and see the next case. But as a consultant myself, I would suddenly need to go to the toilet to cry between patients. Nobody knew. When you've done a clinic full of breaking bad news and dealing with the emotional wrath that patients and their relatives have, what do we do with that? We don't get counselling or coaching to deal with the emotions we take in on a daily basis. We're just meant to go home and be a husband or a wife or a mother or a friend. And I really think we need to find ways of helping the staff dealing with difficult patients. And by difficult, I mean anyone who's got a problem that you can't fix, anyone who you are making their lives worse to try and make them better. How do we help the staff deal with these things? I used to try and do a cuddle club. So at the end of clinic, we'd all just stop. Instead of rushing off on a Friday to go home and get the food on, we just stop and say, who made you laugh? Who made you cry? What do I need to be aware of? Just to try and lighten that load. Because we deal with really difficult things as healthcare staff, and we are patients ourselves. And I remember when I had my mastectomy and I was high as a kite knitting in the early hours of the morning on morphine, nurses came to me and talked about their own cancer experiences. Because they knew I'd gone public with mine, I was someone they could share it with. They didn't know who to talk to in the organisation. And I think we just need to realise that everyone is a patient, but the patients are people too, and we need to help them live the best life they can to the best of our ability. I hope this conference has a load of really inspiring conversations that get you thinking so you can go away and make a difference tomorrow.